Thanks, Dr. Rajiv. May I go ahead? Thanks, Dr. Rajiv Raman, IACON team and Maharashtra Orthopaedic Association for giving this opportunity. After going through all the talks and the nice video demonstration, the whole aim of presenting this relive video is to go through the thought process of the complex knee injuries, which we are nowadays facing quite frequently because of high demand of the patient and more expertise we are gaining in our surgical skill and understanding of the pathologies. So this is a 34-year-old software engineer from US, basically Indo-American. I've shifted to US since last 6-7 years. He regularly plays football in the weekends and is a fitness enthusiast, wants to run, gym and play. Had injury to his knee 1 year ago, was treated conservatively there, but still not happy and complain of pain and subtle instability, but pain is predominantly there. Clinically, there is medial joint line tenderness, posterior drawer positive. Dial test was negative, varus valgus stress was negative, no McMurray's full ROM and alignment was normal. The X-ray here is single leg weight bearing AP view and the lateral view, which shows some reduction in the medial joint space, but no obvious arthritic changes. Went ahead and did his MRI, which shows that there is a posterior horn medial meniscus root tear, as well as there is some PCL fibers are not that clear, but PCL injuries are mainly clinical diagnosis. The ACL is intact, and you can see a subtle subchondral cyst on the medial femoral condyle with bit amount of cartilage loss. So with this patient having PCL, chronic PCL, posterior medial meniscus root tear with some cartilage, it's always advisable to have a standing scanogram and to know the alignment of the limb, which was quite normal here. Even MLDFA and MPTA were normal, but joint line congruence angle was less than 2 mm, which 2 degree, which indicates that we are dealing with some chondral damage, either on the femur or the tibia, but no extra-articular deformities. So with all this thought process, I went ahead and told patient that he needs arthroscopic PCL reconstruction, root repair, and some management of the chondral defect. Depending on the size, it may be microfracture chondroplasty, mosaicplasty, or BMAC, as I kept it ready. So the first step is evaluation and anesthesia and diagnostic arthroscopy. As you see, there is a classical posterior sag sign positive, as well as you can see the sloppy ACL sign, which indicates that's a chronic PCL insufficiency. That's the amount of chondral damage on the medial femoral condyle, a very big amount chondral damage extending from anterior to posterior and distal. Secondary signs of chronic PCL injuries, some chondral injury on the patella grade 2 is also seen there. The anterior and the mid part of the medial meniscus looks to be intact. The tibial cartilage was normal. And through Gilchrist view, you can see that there is a posterior horn, medial meniscus root tear, and that intact white shiny fibers are there. So with this, the process starts. I always prefer to take peroneus longus as my preferred graft for isolated PCL reconstruction. For a few reasons, you have a long graft and a thick graft. I do single bundle remnant preserving PCL reconstruction. So in that you need to have really 9.5 to 10 mm diameter, which you can easily get with peroneus longus tendon. I do inside out femoral drilling technique. For this, your viewing portal should be high anterolateral portal. The low anterolateral portal is your working portal. Be careful while doing that. Do not damage the anterior horn of lateral meniscus as well as the cartilage on the lateral femoral condyle. The tunnel should be as high as possible in the roof and as close to the cartilage as possible, as you see here. I always prefer to remove the soft tissues around the tunnel mouth, because the healing takes place at the aperture and not in the tunnel, and try to preserve the posteromedial bundle as much as possible. The next step is to create a window between ACL and PCL, and I remove the septum for 2 reasons. Because as soon as you remove the septum, the capsule falls back and you have enough space to work, and the soft tissue neurovascular bundles are preserved. I do only posteromedial single portal, which is as high as possible, because you need to have that oblique trajectory to clean the posterior footprint, the footprint on the tibia. The one important technical tip here: keep the mouth of your shaver towards the bone and not towards the capsule to prevent neurovascular damage. Once you finish cleaning, you can clearly see the footprint of the tibia of the PCL on the posterior aspect of the tibia. The champagne glass is clearly visible. That's the meniscofemoral ligament, and that's the way you should visualize from the posterior medial portal. The next step is to pass your PCL guide, tibial guide from the anteromedial portal between the two cruciate and see that you're parallel to the tibial plateau and minimum 15 to 18 millimeters below it and slightly lateral to the footprint, and see that you are quite below. If you are quite proximal, you are likely to damage the posterior horn of medial meniscus. One more technical tip to prevent neurovascular bundle is see that the tip of your bead pin is fixed at 4.5 centimeter because the tibial diameter anteroposterior thickness is rarely beyond 5. So once you reach that, gently tap with the help of mallet and slowly see that your tip comes out. Then you overdrill it with whatever diameter graft you have and finally pass the graft from distal to posterior. I use adjustable loop because it's easy to flip the button and then pull the graft in the tunnel. So that's the view from the posterior medial portal, and you see how the graft beautifully sits and way posterior and inferior from the tibial plateau. And as soon as you tight it on the tibia, the slackness of the ACL goes. And that's the single bundle PCL reconstruction in this case. So in this case, I fixed the PCL femoral side first and left the tibial fixation. Went ahead, the next step is to see the reducibility of the posterior horn of medial meniscus. It was getting reduced not to the anatomical level, but little medial to it, being a chronic 1-year-old injury. So the steps involved in this is first you do MCL pie crusting, nicely shown by Nagraj how to do it, so that you open the joint space and do minimum damage to your cartilage. Then once you open the medial joint space, you assess the reducibility of the meniscus. Then you see the footprint and prepare the footprint by removing the cartilage. Use various jigs which are available from various companies, or you can use your simple ACL jig also to make the entry. And that's the point where you see. And once you see the footprint should be prepared well the way you do in your cuff repairs, as you see in this video. So that, and then you take a bite with the, either you take a single bite or double bite depending on the quality of the tissue. So I have started using tapes which gives a broader surface and contact area. So this, the same patient, that was the different patient, just to show the footprint preparation. So same patient here, I have used inside out femoral tibial drilling method, fixed it anteriorly, and that's the PCL fixation. So once I finished with this PCL fixation on the femoral side, root repair I have done and fixed it on the tibia, but I have not yet fixed the PCL. Went ahead and opened the joint and now planned for BMAC for cartilage damage. So here you need to aspirate very gently and slowly aspirate the bone marrow from the anterosuperior iliac spine. Depending on the size of the lesion, you need to aspirate minimum 80 to 100 ml of bone marrow aspirate. Then the company provides with the vessel. You transfer it, all your bone marrow aspirate into that double, triple compartment vessel, which the company wraps up with you in the surgery. Heparinized syringe should be used so that the blood doesn't become clot in the syringes. Once you finish taking, that's the syringe where you see the whole of the bone marrow aspirate which you have taken it in there. Then you have to centrifuge it at respective RPM for 7 to 8 minutes, and whatever remains down there in the lower compartment is what mesenchymal cells are there, called as buffy coat. It consists of part of red blood cells, little part of plasma, but most amount of buffy coat, which contains significantly rich mesenchymal cells. Then you aspirate it, and then with this double plunger, you need to slowly plunge it because it contains glue. Be very slow, it should not spill down, and gently paste it on the defect. This is of some other case, just to show how you paste that bone marrow aspirate on the chondral defect. So this is again the same patient after doing PCL and root repair. You need to prepare the bone bed very well for cartilage injuries. Remove all the debris from the subchondral bone. Use a sharp 11 number blade and remove all the loose cartilage ends. See that the cartilage ends are perpendicular to the subchondral bone. and then you measure. The size of the defect here was 1.5 by almost 5 centimeter. And then you do your BMAC technique as shown and paste it. The BMAC sticks very well on the cartilage, and that's the reconstructed PCL tendon also seen. That's the immediate post-op X-ray, and that's the video patient has sent me after going a rigorous rehab program. This is at the end of 12 months. He is able to do almost everything, all activities. I prefer to use dual fixation on the tibial side of the PCL, bioscrew as well as a suture disc, and that's the endo button for root repair. The rehab protocol is very slow in such patients. Strict non-weight bearing for 2 months. Knee flexion starts immediately but slowly, and strengthening exercises after 3 months. Normal weight bearing after 2 months. Any hopping and everything like this after 6 to 8 months. The hardest exercise right now is. Thank you.